Hi, I'm Richard Caddy and welcome to this latest podcast from Midlands and Lancashire Commissioning Support Unit. Today I'm talking to Julie Harrington from the CSU's Court of Protection Service. Hi Julie.
Hi.
The Court of Protection Service is one of the specialist services that the Commissioning Support Unit runs, and it's all to do with protecting the best interests of our patients. And to save Julie talking through one of those cases now, we're just going to play you a bit of a case study about a patient whose name is Rose. That's a pseudonym.
Rose was 61 years old and had a learning disability classification, although she had never undergone a formal assessment. She had spent time in a mental health unit and had some personality disorder traits. She would often get preoccupied and do things which directly contradicted recommendations from healthcare professionals, which significantly impacted on her physical health and well-being. Rose had had a number of different interactions with the health system, some good, some not so good, and that meant she found it difficult to follow advice. She was admitted to hospital with complex issues, and when her symptoms were at their worst, she made good decisions. But when her pain had eased, she didn't follow the recommendations and refused to attend further investigative appointments. Rose used her knowledge of the system and her negative experiences to avoid engaging with healthcare professionals and evade the treatment recommended to her. She would move appointments to different hospitals, disrupting and delaying her care. Her GP even tried multiple phone calls and home visits outside of normal working hours, but still to no avail. Professionals couldn't agree on whether Rose had the capacity to make decisions, and so consideration had to be started to determine the appropriate legal pathways under best interest processes. Rose attended investigative appointments and benefited from the support given, but it was determined by an independent assessor that she lacked capacity at that moment in time. But this could improve with the right therapies. Unfortunately, Rose was then diagnosed with confirmed stage 4 cancer and needed to be admitted to hospital. Rose formally objected to this deprivation in not being allowed to return home, despite not being medically fit to do so, and her advocates submitted an objection on her behalf. Rose knew how significant the diagnosis was and that she was dying, but couldn't appreciate her life expectancy and the reality of her deteriorating condition. She wanted to return to her flat, but didn't want to die there. Rose wanted to spend her final days somewhere with gardens and where she could have visits from her cats. Agencies were working collaboratively and sensitively to engage with Rose and ensure that her wishes were at the forefront of decisions being made. They were trying to be creative in tailoring packages of care to meet her needs. Sadly, due to the rapid progression of the disease and the increasing nursing and care needs, returning to her flat was no longer possible. A hospice was chosen with Rose's input, and a room was chosen with a garden and views of animals, something else which was important to Rose. Her final days were spent near the sea, supported by the professionals who still had a role to play in her journey. The unconditional compassion to ensure her departure from this world was as peaceful as it can be continued until the end. The others were left to reflect and feel a sense of accomplishment in that, for Rose, they did their best.
Right, Julie, that sounds a complex and harrowing case to be involved in. Is that typical of the CSU's work?
That is typical of work that we would do in the CSU on behalf of our ICB clients. We are often requested to take over very complex cases where capacity is at question, and often where there's a really complex decision, like in the case of Rose. We will then support all the practitioners involved, be it from a trust or a local authority, to work collaboratively to progress that case for that person, either as an MDT, as a multidisciplinary team, or through the Court of Protection on behalf of the ICB.
And throughout this work, what is the priority?
The person is always the priority. We always operate a person-centred approach. We always keep the person at the centre of their care and make sure that at all times the best interests and the wishes of that person can be followed through, as in the case of Rose.
Right, but with Rose, she was somebody who obviously had learning difficulties, had very set patterns of thought. How complex was it to prove that she didn't really have the capacity to make her own decisions in her own best interest?
So with a case like Rose, it is quite complex because what the assessor is more looking at is executive functioning of that capacity. So Rose could very easily say, when asked what she was needing and what the treatment was, and agree to that. However, when it was actually requested that she needed to put that into practice or follow it through with the treatment, she couldn't always apply that. So it was a case of that she couldn't always use the information to make an informed decision. So those cases are very complex and difficult to assess under the Mental Capacity Act.
Because Rose clearly knew, in inverted commas, the system, didn't she? And was able to manipulate highly qualified professionals to a certain extent. So how do you therefore define that she can't make decisions for herself?
Part of that stalling or delaying or requesting more and more elaborate processes to take place for Rose for the treatment to be completed shows that Rose, although understanding that she needed the treatment or she needed to be in hospital to have further investigations, possibly her ability to then apply that was a bit more clouded, and so she would then use those techniques to stall or delay or request to go to another hospital and another hospital, all the time trying to just delay any action. Although on paper, when you speak to her one-to-one, she would say, yes, I realise that. When she had to actually go through with it, she almost in a way forgot all that and was like, no, I just don't want it.
A lot of people don't do things which are on their best medical interests. They don't have their COVID vaccinations. They don't get regular smear tests or other kinds of tests. And they're allowed to do that. So if Rose doesn't want to act in her own best interest, why should she have her liberty deprived?
So that's part of the Mental Capacity Act, that you don't assume someone is lacking capacity purely because they're making an unwise decision. In Rose's case, there's other factors involved in that. So it's around the fact that she already had the underlying diagnosis of a learning difficulty. She had been involved in mental health services as well, which doesn't mean that everyone involved in mental health services doesn't have capacity, but it's about you have to evidence that there is a reason that you're even considering capacity. So there's your diagnosis. So that's the functional side, functional test. And also in those instances, for example, where someone is refusing to have a smear test, you would be asking them, do you know the outcome? If you don't have it, if they're able to say, yes, I completely understand the outcome to that, and there is no underlying diagnosis, then that's their decision to make. In the case of Rose, when professionals were speaking to her and saying, well, this is really significant, Rose, you could end up, passing away, unfortunately, and being in a lot of pain, she wasn't able to apply that to her decision. So her decision was being made on something that wasn't relevant to the consequence of that decision.
Right, okay, so these cases won't come before a court, like the Court of Protection, unless they're complex, will they?
No.
In Rose's case, things seem to escalate rather quickly because the CSU initially got involved for an initial medical problem that Rose has, and it then escalated because she also got a cancer diagnosis. Are a lot of these cases very, very urgent because of the severity of the patient's illness?
Yeah, so there can be different reasons why we'll take a case to the Court of Protection. It can be a disagreement between professionals and the family, can be a disagreement between all the professionals involved. But in terms of Rose, the one thing that was constant was that everyone involved were trying to work collaboratively with Rose to give her the best possible outcome. I think having the correct people around the table at the right time can prevent that from being an urgent need to go to court of protection, and it can, if you've got the skilled professionals involved, they can recognise, actually, I think we need to look at getting an outside opinion of this now, and so it isn't as rushed and it isn't last minute.
Right, okay, we've spoken a bit about Rose then, and I think, well, it's a very sad case. It's one that had an outcome that was as good as it possibly could have been. Let's talk a bit about the Court of Protection and deprivation of liberties in general now. My understanding is that these cases are normally brought either by the local authority or the NHS. Can you just explain a little bit about the difference between them?
So my team specialise in everything Court of Protection, and that can be either route. It could be a Section 21A challenge, which is brought following a person being placed on a deprivation of liberty within a care home, nursing home or a community. And those cases are brought by the person's representative, the person or their advocate, or anyone who believes that the care has significantly changed and isn't meeting the person's need, or they are objecting. Those cases allow the person the right to appeal their deprivation before a judge and have their opinion heard to make sure that we are operating with the least restrictive available option to us, and that it is in that person's best interest. You know, if there's a disagreement between professionals, we would take it to the Court of Protection under a welfare. We often take younger people, so that it's the 16 to 17-year-olds who come under a Mental Capacity Act. So those often result in, for example, they could result in the deprivation being authorised. And then we also look at, on behalf of our ICB colleagues, we look at community deprivation of liberties. So we complete those on behalf of the ICBs. And they are where people are deprived of their liberty but in the community and are funded by health.
You're talking about a very complex legal process involving people who are usually quite severely ill. So is your background, are you a clinician?
Yeah, so I'm a social worker by background, and my team is a mixture of social workers and nurses. So we complete all the paperwork for the Court of Protection deprivations of liberty. We do all the capacity assessments, we review all the care plans, and then we put it through to the Court of Protection. In relation to 21A challenges or welfares, we have to employ a legal team to manage those. And our part that we play within those is collating all the required information and inputting those into statements, which are then presented to the judge. And the reason that we have to have the legal team for that is because that is they are heard before a judge, so we'll often need a barrister because most people can't speak to judges.
And this is such a specialised area. How do people come to join a unit like this?
So a lot of our team have just completed or have already previously completed best interest assessor training, which is the training that is needed to do deprivations of liberty for people in nursing home and care homes, which is a lot more streamlined than the community system. They have all got a background in specialising in mental capacity assessments. They've all carried out several mental capacity assessments before joining the team, and then since joining the team, it's their bread and butter now, really. They've all got a genuine passion and interest in making sure that the person is kept at the centre of everything and everything is done in their best interest. And just because potentially they may lack capacity doesn't mean that their views and wishes and thoughts should not be heard.
So at the end of the day, why do you get involved in social work, or why do you get involved in nursing? It's to help people when they're vulnerable.
Yeah. exactly that. As you say, it is a specialist sort of niche area in a way. So you may very well not have capacity to decide what to do with your finances, but that doesn't mean you haven't got capacity in every aspect of your life. And unfortunately, this isn't always understood. So we are also champions of making sure that that's understood and heard, and, you know, and we're happy to support other practitioners to develop and learn about that.
Okay then, Julie, what are the advantages then of an ICB coming to use the CSU service?
Okay, so I think our service produces a high quality standard of work, and it can work through backlogs of community deprivation liberties that an ICB has. If the ICB are just managing the court of protection deprivations liberties themselves, this is often an add-on to someone else's day job, which would mean additional pressure on those practitioners who are already carrying out another job, for example, a CHC nurse. We are that dedicated team that purely focuses on mental capacity, community deprivation liberties, any challenges in the court of protection, so we can apply all our expert knowledge and skills to those areas to make sure that we get the best outcome for the person, but also a really good outcome for the ICB that's as cost effective as possible.
Good for the NHS, good for the patient.
Yeah.
Right, Julie, that's been a fascinating discussion about an area of the CSU's work that I had very little knowledge of. Thank you very much.
Well, thank you.
If you would like to know more about Midlands and Lancashire Commissioning Support Unit, go to our website mlcsu.co.uk.